Greetings. I'm looking forward to getting to share with you today about what we're learning from the circumstances of women who developed genital fistula, and particularly what we can say about how fistula etiology may be changing over time in 9 countries in Eastern Africa. So what we'll be covering today, I'll give you a little bit of background about genital fistula. We'll talk through the methods of our project, and I'll walk you through the results, including the circumstances of fistula development, rare causes, and implications of what we're seeing. Then we'll talk through some limitations of this project, and then we'll get to the conclusions. I look forward to your questions and discussion after the presentation. So my name is Carrie Ngongo, and I'm calling in from Seattle in the United States. And I previously lived in Nairobi, where I got to know and work with the fistula surgeon, Dr. Thomas Rossen. And here we're pictured with Dr. Marietta Mahendika. And today I'm going to tell you a bit about what we can learn from decades of dedicated work from them and their colleagues. Our story begins with Dr. Rossen and Dr. Mahendika traveling to hospitals that offer fistula repair surgery. The travel was to 9 countries: Tanzania, Uganda, Kenya, Malawi, Zambia, Rwanda, Ethiopia, South Sudan, and Somalia. They were going to carry out fistula repairs. But what is fistula? So genital fistula, or urogenital fistula, is a broad category describing any abnormal communication between the genital tract and the bladder, urethra, ureters, colon, or rectum. Most genital fistulas occur when women experience prolonged obstructed labor and do not receive a timely cesarean section. Obstruction occurs when the presenting part of the baby cannot progress any further in the birth canal, despite strong uterine contractions. And that can be due to cephalopelvic disproportion, or malpresentation, or malposition. The obstruction can cause the baby to die, which happens around 90% of the time in women with fistula. The pressure of the baby's head against the mother's pelvis can lead to pressure necrosis. The tissue dies, and the woman is left with a fistula. Obstructed labor occurs in an estimated 4.6% of all childbirths, causing 8% of maternal deaths. Not all women who experience obstructed labor are able to access emergency obstetric care in time. So what's it like to live with fistula? The chronic morbidity of genital fistula is associated with long-term medical, physical, psychological, social, and economic consequences for women. Leaking of urine produces painful rashes and a bad smell. Stigma may prevent women with fistula from cooking food, performing household chores, participating in religious rituals, or engaging in income-generating activities. Some women with fistula may avoid public gatherings and social events. Many women with fistula seek to hide their incontinence. Many are severely depressed. While most fistulas develop when women experience prolonged obstructed labor and do not receive a timely cesarean section, there are other causes of fistula. This slide provides a list of non-obstetric genital fistula causes from the 2022 FIGO Fistula Surgery Training Manual. Genital fistulas can develop from accidents during any pelvic surgery, such as cesarean sections or hysterectomies. Any surgery carries some risk of provider error. Healthcare providers may inadvertently injure the bladder, ureters, vagina, or intestines. And when this happens, fistulas are called iatrogenic. Less frequent causes of fistula include trauma, infection, cancer, radiotherapy, and congenital malformations. When we consider the causes of fistula reported in Africa, here are 2 historical examples with large samples of women presenting for fistula repair over several decades. One is from Dr. Mulu Muleta and colleagues in Ethiopia, while the other is from Hilton and Ward in Nigeria. As you can see in dark blue, most women seeking fistula treatment have obstetric fistulas following childbirth. In red, you can see fistulas caused by gynecological surgeries. In the pie chart on the right, you can see that rarer causes account for small slivers of the overall genital fistula burden. These two examples illustrate the usual narrative about fistula causes in Africa. Fistula is generally obstetric due to childbirth. A smaller proportion is iatrogenic fistula from gynecological surgeries. You might notice that these charts do not include anything on mode of birth or iatrogenic fistulas following obstetric surgery, and we'll get to that. So the overall goal of our project has been to learn from the experiences that led women to develop fistula. We wondered about how the causes of fistula might vary by country and over time. So Dr. Rawson and Dr. Mahendika conducted fistula repairs in 89 facilities over 23 years. They and their colleagues collected detailed information about the women that they treated between 1994 and 2017. The women had developed fistula earlier in an unknown larger number of locations sometime before seeking treatment. At each facility, the providers interviewed and examined women presenting for fistula repair. They documented women's self-reported data about how their fistula developed, their obstetric history, and their socio-demographic details. After surgery, the operating surgeon documented information about the fistula and the surgery itself, including the location and size of the fistula. We converted the paper forms to an Excel database, and we captured 96 variables for each of 8,720 surgical records. So I'd like to share with you our results, largely drawn from two papers that we published in 2022 in BMC Pregnancy and Childbirth and BMC Women's Health. This work summarizes the circumstances of fistula development in 6,787 women who developed fistula in the 9 countries and sought repair between 1994 and 2017. So here's a pie chart presenting our data in the style of the earlier pie charts that I showed you. You can see that most genital fistulas in the 9 included countries follow childbirth. Considering the mode of birth, however, we can divide this dark blue between vaginal birth, which is still dark blue, and cesarean birth, which is light blue. When we consider the differences between the 9 countries, we concluded that access to emergency obstetric care remains a clear challenge in South Sudan, Somalia, and Ethiopia. Access appears higher in Kenya, Malawi, Rwanda, Tanzania, Uganda, and Zambia, signaling potential progress in obstetric fistula prevention. If we dig into that other causes row, we can see that rare causes illuminate a range of risks confronting women. The most common of these are traumatic, including accidents, sexual violence, and injuries from traditional healers. After this comes unsafe abortion, followed by radiation, complications of HIV infection, and congenital abnormality. The relatively low proportion of fistulas attributable to sexual violence suggests that genital fistula is a relatively infrequent complication of sexual violence. The same is true for fistula following unsafe abortion. The fistulas due to trauma from traditional healers were seen mostly in Somalia and Kenya, where traditional healers used intentional vaginal burning to treat a variety of complaints. Health education and outreach in Somalia and Kenya should stress that intentional vaginal burning is not an effective therapy and may cause substantial harm. This large data set offers a unique opportunity to assess the circumstances of fistula development in 9 African countries. It is not without limitations. First, the work is a retrospective records review, and an inherent limitation of retrospective records reviews is that inferences must focus on associations, not causation. We rely on women's accounts of past events, and we acknowledge that women's recollection of childbirth may differ from how providers diagnose obstetric problems. This data set includes only women with fistula who presented for fistula repair. It does not include women who died from unattended obstructed labor, and it does not include women who were spared a fistula thanks to appropriate management of prolonged labor and timely cesarean birth. Reliable data are not available for us to make comparisons with wider groups, such as the total number of women developing maternal morbidities or giving birth in the included health facilities. Our data set likewise does not include women who developed fistula but did not reach treatment facilities. Women with fistula who seek treatment may differ from those who do not. And our conclusions about fistula causes may be different among all women with fistula if some women are more likely than others to reach treatment facilities. Finally, the included countries have different sample sizes based on where Dr. Rasan, Dr. Mahendika, and colleagues conducted fistula repairs. We do not have a reason to doubt that the women in our review were representative of all women seeking fistula treatment, but selection bias is possible. Countries typically included data from multiple hospitals with wide catchment areas, and the countries with large sample sizes may be more representative of all women seeking fistula repair in those countries than those with smaller samples. Taken together with our work on understanding the proportion of fistulas that following cesarean section that are likely iatrogenic in origin, we can add some nuance to the pie charts that I shared earlier. So you'll recall that the dark blue shows fistulas following vaginal births, and the light blue shows fistulas following cesarean births. And considering the location and circumstances of the fistulas themselves, we can further divide the light blue between fistulas that are attributable to prolonged obstructed labor and fistulas that are likely iatrogenic injuries from surgery. We can see the two shades of red conveying two types of iatrogenic fistula: iatrogenic fistula following gynecological surgeries and iatrogenic fistula following cesarean section or other obstetric surgeries. Here's a view by country. In Somalia, South Sudan, and Ethiopia, the proportion of fistulas following obstetric or gynecological surgery remains small, and most fistulas follow vaginal birth. In contrast, women with fistula in Kenya, Malawi, Rwanda, Tanzania, Uganda, and Zambia increasingly have reported cesarean births. Iatrogenic fistula constituted roughly a quarter of the fistula caseload in these 6 countries. The takeaway here is that in the countries where women have greater access to emergency obstetric care, we can see that women with fistula are more likely to have given birth by cesarean section. The most common cause of fistula in the 9 countries is childbirth, followed by surgical complications, and rare causes together account for around 1% of the overall fistula burden. It does appear that fistula etiology is shifting as women increasingly gain access to care. One would expect the proportion of iatrogenic fistulas to increase as countries make progress toward obstetric fistula elimination. The question is not so much about the proportion of iatrogenic fistula within the overall caseload of genital fistula in health facilities offering treatment. Rather, emphasis must be placed on the number of women who suffer needlessly from injuries that could be prevented by high-quality emergency obstetric care and safe surgical care. Addressing the continuing burden of genital fistula will require a health system strengthening approach that improves emergency obstetric care and surgical safety. We recommend taking the time and effort to review cases in order to improve the quality of care. Diverse causes of fistula call for multi-pronged strategies to reduce fistula incidence, including attention to safety and quality of care. I'd like to thank and recognize my co-authors in this work, Dr. Rasan and Dr. Mahendika, as well as Ladesha Lombard and Jos van Roosmalen and Marlene Temmerman. We would really like to thank the caregivers who provided for the women during their hospital stays. There are many different organizations who generously supported the travel to the different fistula repair hospitals over the decades of work, and we'd like to recognize them here. So I'd like to open it up for questions. Please feel free to email me in case of any questions for those of you hearing this presentation rather than seeing it in real time. And I thank you very much for your attention.